I'm very excited to introduce the last member, Dr. Paula Kitto. Paula, I was just trying to work out before. Paula and I first met, and we both teach the rural clinical school of 50 students. And I first met her a couple of years ago after, I'm not sure how long after she'd come back from Somalia. She's been there on a couple of occasions. And listening to some of the stories, it was just mind-boggling, and I thought that it would be a great opportunity to share some of her experiences, and she may not be sharing some of her experiences, and you'll soon see why. But Paula, I've then gone on to, we say we're co-organisers of the course. I'm really her lucky, I think. She does most of the work with the 50 medical students in one of our courses, but I really enjoyed working with Paula over the years. So Paula is a rural generalist and GP obstetrician based in SA, and she splits her time between Kadina, Wallaroo and Port Lincoln. She was born and raised in rural SA prior to moving to Adelaide to undertake her medical studies at Flinders University. Paula undertook her postgraduate studies in the MT before moving back to SA, and over the years has worked in most states of Australia in addition to several overseas countries. I'm really excited to introduce Paula, so please give her a warm welcome.
Thank you, Alice, and thank you to all of you guys for turning up, or all of you ladies for turning up. And this is something a little bit different to what everyone else has spoken about, but hopefully I won't put you all to sleep and we won't take too much of your time. I just want to start off acknowledging traditional owners and custodians that are here on today, or whose name we're on today, and recognising their connection to this land, to the waters nearby, and acknowledging that sovereignty was never ceded. I want to pay respect to elders past and present, and extending that respect to any First Nations people who might be here today. So, how does a GP from Australia go somewhere over there, and where was it? So this is just a little geography lesson in case anyone needed it. Hopefully people can recognise what Africa looks like on the map. And then on the little eastern horn of Africa is a relatively war-torn country that we know as Somalia. I refer to it in my title slide as the Somali horn of Africa. And that's because the Somali people inhabit a reasonable portion of Ethiopia, Djibouti, and the country of Somalia, which is kind of split. It's probably politically contentious, but Somaliland in the north declared independence almost 25 years ago. They don't have any oil, so the world doesn't want to recognise them. But a lot safer than some of the areas in the south, although still quite war-torn. I've been working there on and off over the last 10 years, and working the majority of that time at University Hospital and the university there as well. So back in 2012, I think, I first went there. And I turned up in the hospital over there, and the local doctor said to me, "Can you do obstetrics?" And I said, "Yeah, I can do obstetrics." He said, "Good, you take that half of the hospital and I'll do this half of the hospital." So there are two of us for the hospital, which functions as close as it can be to a tertiary referral centre in a country that has no functioning health system. So I spent the first few days trying to work out which way was up. Noticed as I was doing my ward rounds an unusual phrase, and I'll sometimes say to the nursing staff, "Where's this lady's baby?" And they said, "Oh, that one didn't cry." And so after a couple of days I said to them, what do you mean that one didn't cry? And before I continue my story, I should have said before, I'm sorry, I realise this content is confronting for some people. I hope to bring it across in a way that there is hope, but if anyone wants to talk about stuff after, I'll get any time I'm happy to. Okay. So I said to the nursing staff, "Okay, what do we do if it doesn't cry? What do we do if the baby doesn't cry?" And they said, "Well, you wrap it up in and a cloth, and you give it to the grandmother, and she will go and bury it. Okay. Like, do we do anything else first? And they looked at me and thinking, like what? And it became apparent that nobody had ever taught anyone there about neonatal resuscitation. So baby came out, it didn't cry and it didn't breathe by itself. It didn't make it. We know that if all we do is help the baby take a few breaths, 70% of neonatal deaths are preventable. Okay. And they just did not know. That conversation led me to go back there with an NGO. One of the various different things we did. One of the things we did was a project which runs internationally. It's called Helping Babies Breathe. And it just teaches people very simple things. It has a very basic, reusable bag that you can help the baby breathe with. A very simple way to suction some mucus if you need to, and then teaches people the importance of keeping the baby warm, washing your hands, just very basic things. So as that started to roll out, one thing led to another. If you're going to start resuscitating babies, you're going to have some sick babies that need to be looked after. So there were, at the time, 10 years ago, no paediatricians in the country, and there was no neonatal unit in the country. We did find in the back of a donated shipping container a couple of incubators, and so we figured we better train some nurses in how to look after babies. And so it became a process of training. You know, one thing leads to another thing, leads to another thing. Over the last 10 years, we now have around 700 people that have been trained and are all over the country who can resuscitate a baby and help the baby transition to life outside the uterus, which is awesome. The other thing that people always use is babies under 37 weeks can't survive in Somalia. It's not possible. This was entrenched to the point where if somebody came in and there was evidence of distress in early labour at 36 weeks, they would not do a caesarean section because they said the baby can't live anymore. So it took time to change the culture, change those things, and we started talking to people about kangaroo care. Kangaroo care is just skin-to-skin care. Obviously, Australians, we know what kangaroos are. I don't know how some guy in India coined the term kangaroo care. I do know there is not a single person outside of Australia that actually understands what we're talking about when we talk about kangaroo care. And people were quite resistant to it. So we reached a point where we knew if we had a baby that was born and it weighed over about 900 grams, it had a reasonable chance of surviving as long as the mum would do kangaroo care, because people couldn't afford to stay in hospital. Okay, if you have a baby that weight here in Australia, it's in hospital for 6 months or more. Our discharge goal weight was 1100 grams. Okay, so here you would be usually 2.2 kilos, or more, but there's no point keeping a baby in hospital if its presence there means that the family can't feed the rest of their kids because they've got no money for food. Mariam and her little boy Abdi were one of the first ones, and she was a lady who just wouldn't give up. All her family wanted her to give up, and it was quite frequent that we would have families come in and want to discharge their babies from the unit. And Mariam would come in the morning, she'd say, oh, my family are coming today, so I'm running away to hide, but I haven't abandoned Abdi, I will be back. Okay, and that was her thing for about 4 or 5 weeks. She'd hide whenever her family came, so that they wouldn't make her leave. He bucked the odds, and that was at his, I think, about 3 or 4 month check. So she was one of the first ones who actually kind of understood kangaroo care. Somaliland at the moment is, they're saying it's the worst drought in 90 years. So there's famine and there's also civil war at the moment. Despite both of those things, it still remains that the most dangerous thing a Somaliland woman can do is get pregnant. If you are living in Somaliland, your risk of, as a woman, of dying from a childbirth-related cause in your lifetime is 30%. 30% risk, which is massive. And we know the things that affect that are not rocket science. You know, yes, you need to have good nutrition. Yes, you need to have access to a skilled birth attendant. You need some pretty basic sets of skills to make a difference with that. So, in a country where those skills were lacking, we got involved very much in education. And the Somali people love to learn. They are generally good at remembering things and not great at practical things. So we have to, reinforce things quite often. And a few years ago, we put together a program which the Fistula Foundation ended up funding for us for doctors over there. So there wasn't, when I first went there was no graduate training at all. So we wanted just to provide basically a 12-month program that taught them how to do safe obstetrics, safe caesarean sections, but also how to look after sick babies, because there's no paediatrician to handle sick babies. So we started working with that. When I go back, I still get involved in those things. So we've now, while I was over there last time, we trained the 49th doctor in obstetrics, graduated, which is lovely. And with the skills they've learned when they go to their regional areas, if they share those skills with the staff in the health facilities and communities where they are, we know that the set of skills they have will decrease neonatal morbidity and mortality by about 70%, and maternal morbidity and mortality by about 40%. That's harder to affect maternal morbidity and mortality because there's much more reasons that impact into it. So hopefully they've got a good skill set to get started with. With the nursing staff, this was a neonatal resuscitation session that we ran recently, and we were teaching them advanced neonatal resuscitation. When you're resuscitating newborn, it's different than when you're resuscitating kids that are a bit older. And so we know as health professionals we'll start doing chest compressions to help their heart beat if it's less than 60 beats per minute. Now, what we discovered is that these ladies who were midwives and nurses couldn't take a pulse. Right? Their education system, particularly the education system that the women have, is such that they don't know how to count for 15 seconds and multiply by 4. So we ended up finding some songs that are at 60 beats per minute, changing the words, indoctrinating, getting people to do CPR at 120 beats per minute is easy because that's Baby Shark and that's the most annoying thing ever. Right, so we had to find an earworm that was 60 beats per minute as well, so then they know, okay, if it's slower than this, then you need to start doing chest compressions. So some of it's just finding different ways to do stuff and finding some creative solutions. Alright. Hope some things are free, sharing knowledge is free. Some things have a cost. This is Fatima holding a little girl. I met Fatima a few months ago. She's 41, and it was the 6th time she had been pregnant. She'd had several miscarriages, and in her previous pregnancy she'd gone into labour in a village. There was no birth attendant. After 3 days in labour, she was eventually brought to the city, and she had a little boy who was stillborn. So I met her when she was 38 weeks pregnant, and she didn't have enough fluid around the baby. 41. She doesn't get a lot of chances for pregnancy, and so I said to her, you know, look, we can induce labour, and there are some risks with that. It's very challenging to monitor labour closely over there. But you know, if you want to, we can have a cesarean section. It's the safest way for you to get a healthy baby. And she talked with her family about that, and they really wanted that. But cesarean section costs about 6 months' wages. And Somalia's in the middle of drought at the moment. So we quick phone call to some colleagues back in Australia, and they said, yep, let's do it. So she got her little girl and was absolutely beaming. We often in Australia think, stupid gap fee to see the dermatologist. You're sitting in my field of view. It's probably a stupid gap fee to see the GP as well, and certainly for the gastroenterologist and all these sorts of things. I am grateful that when we need an operation, whether it be for cancer, whether it be for life-saving, whatever else, we've got a public health system and people can get it. You know, sometimes we have to wait for elective stuff, and wait is frustrating, and it's frustrating for me as a doctor and for my patients as well. But it works. You know, there is nothing in the world that is worse than the anguish on a mother's face when she has to choose between a life-saving operation and feeding a children. But that's still the world over there. I was very fortunate this time around. Some of my colleagues, not long before I went, we'd been at an event and I was meant to pay someone back for something. They said, don't pay me back for it. Take the money and see what you can do with it. Just find something useful. So you have to be careful that we're not breeding just dependence, but there is genuine need in it as well. And I was talking with my colleagues last night and I said, oh, just tell them what difference a little bit can make. All right, why not? So we had about 3,000 Australian dollars. Okay. For 3,000 Australian dollars, we paid for neurosurgery for 3 newborns. There's high rates of spina bifida and hydrocephalus over there because there's not enough follow. So we're very fortunate at the hospital I work over there. One of the local surgeons has been trained to put shunts in. So we sorted that. We gave baby a new bum. He was born without one, so he needed one. So he got a new bum. 6 cesarean sections. We had 12 antennates that couldn't afford ultrasounds that we sorted, a couple of CT scans. Someone needed an emergency appendectomy, had half a dozen blood transfusions, 48 days of care in a neonatal intensive care unit, and paid for midwifery upskilling days for 45 weeks. It doesn't take a lot to do that. It doesn't take a lot. This is not about asking for money, just to say that, you know, I'm really privileged to be able to take a little bit and go, wow, it makes a difference. You know, it makes a big difference. Every one of those midwives, you know, and actually, the midwife training cost $120 for 45 people to be updated, and they all spent 2 days training. One was an update in WHO labour care, so safe labour management, and the other was on neonatal resuscitation. You know, it's, you know, $120 to do that is just phenomenal, and it will make a big difference for people. All right, I'm nearly done, I promise. This is Buba. Buba has 14 children. She had her first baby when she was 14, and she's now nearly 40. Their family are very poor and live near one of the areas where rubbish gets dumped. Her son, Cutter, washes cars. And I met Cutter because he used to come around and say, Doctor, can I wash your car? Doctor, can I wash your car? My car's filthy at the moment. I had a very clean car the entire time I lived in Somalia. I came to understand that Cutter wasn't allowed home for the night unless he'd made a certain amount of money from washing cars. And that was because that's how the rest of his siblings were able to eat. So he would come, and sometimes it was quite late at night. Dr. Paula, can I wash your car? Yes, you can wash my car. And so he'd wash the car and he'd take some rice or some potatoes and off he'd go. He came around one night and said, Dr. Paula, I think my mum's pregnant again and she's sick. I said, okay, bring her in. And she was indeed pregnant with twins, and she had quite severe preeclampsia at 27 weeks. So she ended up having preterm twins and was in the hospital, and this was one of her kids. And she gave us this incredible gift, and that's what I want to talk to you guys about in 2 ticks. So, when we come to maternal and child health care, we know that globally, across the globe, every 2 minutes there will be a woman die from a pregnancy-related reason. Still, the women's health globally is appalling. 70% of those maternal deaths are going to be in sub-Saharan Africa. Somaliland and Somalia are number 3 when it comes to maternal deaths, I think, and the second worst in the world when it comes to neonatal deaths, with currently 1 in 10 not making it to 12 months of age. 1 in 10 kids don't get there. So we have to do everything that we can to try and help this kid survive. And we were harping on about kangaroo care, trying to explain it, and it used to drive me absolutely nuts because people just wouldn't do it and they didn't get it and I couldn't explain it and whatever else. So we were trying to explain it to Uba, and one of the midwives, Rhoda, was talking with her and she's translating for me, and then Uba looked at me and she looked at Rhoda and she said, and Rhoda said, ha, which was yes. And she went, ha, which was yes. Stop. What just happened there? What happened there? There was this like light switch had gone on. And what Uba had shared was a saying that her grandmother had told her. There is an old Somali proverb, and what that phrase means is the baby grows strong on the skin of its mother. Okay. And I said, okay, let's not talk about kangaroo care ever again. All right? Let's remind people that there is this awesome proverb, you know, in their history that just needs to be remembered. And I think, you know, this is something that's been my story over there, is that I often find that people who have nothing to give financially have an incredible richness that they can give in terms of knowledge and life and culture and all of those sorts of things. So some colleagues here, some fellow GP obstetricians said, hey, it doesn't take much to make a big difference over there, does it? No. I said, do you reckon people would be open over there if we did a little thing here about giving hope instead of flowers? And I said, I suppose, do what you want. You know, I said, well, it's really nice sometimes patients give us flowers, but we don't need them. You know, we reckon they'd be up for this. So we found a local designer to do us a little picture and put the Somali proverb on the bottom of it. This will come as no surprise to the majority of people in this room, but the male doctors over there are disorganised and useless in putting organiser things. The women are organised, right? So there's actually no Somaliland Medical Association. There's no Somaliland GP Association or gastro or anything like that. Where to be honest, there aren't gastro people, but there are a couple of physicians there. But there's none of that. The only organisation that exists is the Female Medical Doctors Association. So we had a chat with them and said, what do you think? You know, to roll this out across the country, like to, you know, sticker these on every little, you know, on every little health clinic that exists, and you know, maybe a couple of bigger things as well. You know, what do you reckon it would cost? If we could have $500, then we could go and we could do free clinics at the same time we put the posters up. Right, by each clinic. No, total. Okay, let's do that. So we've left these Somaliland female medical doctors to get organised and remind people that there is hope in the heritage, you know, and it's not a matter of taking on board some weird Western concept, but just remember that this is something their grandmothers knew and we need to know. You know. We've got young midwives that are trained to go back out there, and there are, you know, there's always stories of heartache, but for the most part, there's hope, and that's what we have to rest with. You know, ultimately, as the sun goes down, you go, all right, there's always some rubbish that happened in the day, but sun will rise again tomorrow, and there's hope for tomorrow. And there's incredible hope for the women of Somaliland. And it's a privilege to be part of it. It's also a privilege to come back here. That's all I've got to say. Thanks for listening.
Does anyone have any questions for Paula at all?
I just wondered, why Somaliland in the first place? How did you end up there?
Yeah, so when I was training at uni, I knew some refugees that came across from Somalia, and one of them was a doctor. He just used to talk about his country and whatever else. And he just used to chat and say, one day you'll have to see what medicine's like in Somalia. And in all honesty, by 2011, I was totally fed up with medicine in Australia. I was sick of red tape. I was sick of you know, everything from Centrelink to prescribing rules and all these other things. And I thought, I wonder if I still like medicine if it's just about medicine. You know, I take all these other things out. So yeah, I remember the discussions that I used to have with Hassan and with others, and thought, oh, maybe now's the time to go. So I literally Googled hospitals in Somalia, found 2 email addresses, sent off a, this is who I am, oh, it must have been better to invite us back then, and offered them a few months at the end of the year if they were interested. One hospital went back, so I went, yeah, discovered that the health situation there was so bad. It was really, really easy to make a very, very significant difference in people's lives. And I think most people in the health profession go into it at some level because we want to make a difference. And honestly, all I had to do over there to go home at the end of the day and know I'd made a difference was turn up to work. And so it was, you know, I guess at a selfish level, it was very rewarding. It was heartbreaking. It was certainly working at the sharp edges of a broken society. But it was obvious that a little bit of assistance could go a very, very long way. That's what I did, and now I just keep going back there because I'm like, I actually understand the chaos. I've got a relationship with people. I speak a little bit of language very badly. After 5 years of language, my friend said, Dr. Paula, now you speak like a 3-year-old. But yeah, it means now when I go back, even if I only go back for a couple of months, I'm not spending time being a medical tourist. I can slot in and help out the rest of
Thank you, Paula. That was an incredible insight to some of your work. I've spoken to you a few times over the years about some of your experiences, and just in awe about what you've achieved over there, and certainly have made an enormous difference, and it puts things into perspective for us back here, like you say, our healthcare system. I know we grizzle about it sometimes, but we are very blessed to have what we have here. So I'd really like to thank Paula for talking tonight. You've probably had no choice, really, to say you're coming tonight. I want people to share your story, but I really, really do appreciate you coming in and spending the time with us. As with all the speakers, I know I've only got 2 left out of 4. We're dropping like flies, but no, I really appreciate it, and I really appreciate you all coming tonight. This was my idea and vision, that I had a room full of people listening to some fantastic talks, expertise that we don't generally get, and creating a conversation that may already be there but may not, getting you to talk more about these things going home, then to talk to other people, and then talking to your partners and children if it's appropriate age, and just getting that conversation happening. So hopefully I'll be doing 2 more this year, and they may be different topics, so feel free to come along to different towns, and then with a bit of luck maybe continue it on to next year. So thank you all for coming. It's been a great night, I think, and drive safely. Thanks. A medical thing here, or I suppose other organisations, but there's a survey to do. I would really appreciate it. I actually forgot with the men last night. I think it would be helpful for me to show funding bodies, to say that it was worthwhile. It's only a couple of questions. I hate surveys myself. It's just if you liked it, if you thought that they were interesting, if you come to another one, and if there's any topics that you thought might be useful to talk about at other events, I'd really appreciate it. Thank you.